Hello again. We're going to talk here about the middle complement deficiencies. That's namely C3 and C5. Now, a lot of books, texts, literature will divide up the complement pathway into early and late. Late being everything from C5 onward, generating the membrane attack complex, and then early being everything up to and including C3. But considering that C3 and C5 complement deficiencies present a little bit differently, I like to consider it sort of its own class. It doesn't really matter how you want to divide it up, organize it in your mind, but I excluded this here from the terminal complement deficiencies. So we'll start out with the vignette. A 6-year-old boy presents with his mother to the clinic complaining of swelling of the legs and fatigue for the past 2 weeks. There are no other complaints. He was born term via uncomplicated spontaneous vaginal delivery to a G2P2 mother and is consistently tracked in the 45th percentile for weight and the 50th percentile for height. He has been hospitalized twice, at 2 years old and at 5 years old, for meningitis, both of which tested positive for Neisseria meningitidis and resolved with ceftriaxone and vancomycin. Very good broad-spectrum coverage for pediatric meningitis. He has been seen in the clinic twice for pneumonia. He was worked up for primary immunodeficiency, as he probably should given his history, and his B-cell, T-cell, and quantitative immunoglobulin levels were all normal. Family history is non-contributory. Physical exam is significant for facial edema, periorbital fullness, plus 3 out of 4 pitting edema of the legs, and plus 2 out of 4 of the arms. CMP, CBC, and urinalysis are obtained and demonstrate the following. So, our CMP gives us a mildly decreased sodium. Our BUN creatinine are elevated, and the albumin level is low, as we probably expected based on the fact that we have edema in a child. That's not very common. Our CBC was normal. The urinalysis showed elevated protein in the urine. Red blood cells are 2+, and there were red cell casts. So what is our differential? Well, we could certainly include the most common cause of nephrotic syndrome, because that's certainly what this child has. Now, technically, you would have to get a 24-hour urine protein to make the formal diagnosis of nephrotic syndrome, but we basically have it here. I mean, you got the edema, you got the elevated protein in the urine. So we have nephrotic syndrome for all intents and purposes. So definitely you could include in our differential minimal change disease. That's the most common cause of nephrotic syndrome in children. However, this child also has a history of infections, and we cannot ignore that. And the reason we can't ignore that is because we know that there are causes of glomerulonephritis that are associated with decreases in complement. And we also know that decreases in complement can be associated with infection. So we can draw a common thread between this, and that means that we should work this patient up for something beyond just minimal change disease. Now, certainly if your complement comes back normal, then maybe these infections were a coincidence and he's just an unlucky child, and we can do a kidney biopsy for minimal change disease. We would need to do electron microscopy for that. However, this child, based on his clinical history, needs to be worked up for complement deficiency. And so indeed we do that. We find a C3 level that's drastically decreased, a C4 level that's normal, and CH50 predictably is going to be decreased. So we diagnosed this young man with membranoproliferative glomerulonephritis, with nephrotic syndrome, and that is secondary to C3 deficiency. So I'm not going to go over all of, in the early complement deficiency section, I talked about, more in detail, described this whole pathway. I am not going to go over this all again. You can go back there and watch. I talked about this ad nauseum. Suffice it to say, though, that you have a classical and lectin pathway, which are activated by either microbial surfaces or immune complexes. Ultimately, this is going to converge and make a C3 convertase, which is C4b2a. You have another way of making a C3 convertase, which is through the alternative pathway. This is a purely innate pathway. You have tick over of C3, which gets hydrolyzed into C3b. And then that ultimately is going to form a different C3 convertase, which is C3bBB. Both of these C3 convertases have the effect of converting C3 into C3b and C3a. C3b is necessary for the formation of a C5 convertase. So our C5 convertase here is going to be what converts C5 into C5a and C5b. Now, this having been said, we should keep in mind that these other complement factors, even though they don't go into forming convertases or the terminal membrane attack complex, they do still form important, they still do have important roles. So, for instance, C3A is responsible for chemotaxis. There are other things that are responsible for chemotaxis. C4A does it, C5A does it. All of these collectively together, C3A, C4A, C5A, they're known as anaphylotoxins or anaphylotoxins, potato. What they do is they enhance inflammation by inducing mast cell degranulation and neutrophil aggregation. And remember, when you degranulate your mast cells, what you're doing is you're releasing histamine, and that's going to help you swell up. So it increases the capillary permeability. And that, in and of itself, is going to help with inflammation, but then you're also recruiting neutrophils and other various immune components. So if you have a deficiency of C3, then you're not going to be able to form your C5 convertase, but you're also going to have difficulties with inflammation. And so let's just go ahead and, okay, so I'll give you the slide too so you can see that. All right, we're just talking about three of these here. So C3 and C5, and then we're also going to talk about factor I. Factor I has an important role as a negative regulator of the C3 convertase, the alternative pathway C3 convertase, and also as a positive regulator of inactivating C3b into what's known as IC3b, or inactive C3b. Even though it's called inactive C3b, though, it's not totally inactive, and we're going to talk about that. So, all right, we're going to talk about C3 deficiency, C5 deficiency, factor I deficiency. None of these are really common. However, just for the sake of academics, I want to talk about these because understanding these gives you a good idea of what this system does. Okay, so C3 deficiency is by far the most severe disease phenotype of any of the complement system deficiencies. We talk about a lot of them: C1, C2, C4, C3, C5, C6, C7 through C9. There's a lot of complement deficiencies, but C3 deficiency is the worst. 1/3 of C3 deficiency patients will have membranoproliferative glomerulonephritis, and that's what we saw in our patient in our vignette. Now again here, you see, just like in the early complement deficiencies, you see this interplay where you have immunodeficiencies on the one hand, and you have these sort of autoimmune issues on the other hand. With C3 deficiency, what we have is deposition of C3 in the glomerulus. And so because your C3 conversion is so overactive, not only does that cause deposition in the glomerulus, but it also depletes your C3 that you would otherwise use for fighting off infection. So you can see how you get both the membranoproliferative glomerulonephritis, 14 syllables long, and you also get immunodeficiency. Okay, so what is probably the etiology of C3 deficiency? I don't know if we necessarily know, but what I have read in the literature is that there is I don't know if it's, I believe it's an autoantibody known as C3 nephritic factor, and it just happens to be in certain people. And this C3 nephritic factor, what it does is it's an IgG, and it binds that C3 convertase of the alternative pathway, the C3BB. And by binding it, it prevents it from being inactivated. And so you can see here that if your C3BB is not inactivated, if it's constitutively active or overactive, you're going to convert C3 to C3b unchecked. And so that's ultimately what reduces your C3, converts it to C3b, allows for the deposition of C3 components in the glomerulus, and also what is going to deplete your C3 and cause immunodeficiency. Now, patients with C3 deficiency are at risk for Neisseria infections. Why are they at risk for Neisseria infections? If you have deficient C3, you don't form C3b when you need to. If you don't form C3b, so let's say you have Neisseria in your body, normal person would form the C5 convertase by cleaving C3 to C3b. Form that C5 convertase, you can now cleave C5 into C5a and C5b. C5b goes on to form terminal membrane attack complex. Boom, you kill Neisseria. Great, so now a person with a C3 deficiency, they get Neisseria, they can't form the C5 convertase, and subsequently they're not going to be able to form a membrane attack complex, and they're at risk for Neisseria. They're also at risk for pyogenic infections. Why are they at risk for pyogenic infections? C3b, remember, is our opsonizer, and we opsonize encapsulated organisms, pyogenic organisms, and by doing that, we clear out pyogenic organisms. It's one way that we can clear out pyogenic organisms. If you don't have C3b, you are not going to be able to clear out those organisms. And so you are also at risk for pyogenic infections. And we saw that in our child in our vignette. He was seen twice in the clinic for pneumonia. And he could be worse, but he's been seen twice for pneumonia. Pneumonia typically caused by pyogenic organisms. All right. So we see three different types of infections that are characteristic of C3 deficiency: staphylococcal abscesses, recurrent sinopulmonary infections, including pneumonia, and systemic infections, and then, of course, also Neisseria infections, which are typically systemic, or they can be in CNS, like we saw in this child. Patients with C3 deficiency also have difficulty with immune complexes. So they are at risk for developing serum sickness and vasculitic rash. All right, I think that's all I wanted to talk about here. Okay, so even though C3 deficiency is rare, there are certain locations where you see it more. In the Afrikaans population, which I think is like Dutch descendant population in South Africa, they actually have a relatively high frequency compared to everybody else. And that's because of a founder effect. So I just thought I'd add that. Oh, and another thing I wanted to add. So the recurrent sinopulmonary infections, yes, that is due to a defective opsonization, but there's another thing here. So remember that in order to, okay, so you have your C3b, right? You're not going to have as much of this when you have when you have a C3 deficiency, because you need C3 to form C3b. Yes, it is true that the basis of this is that you're using up all your C3, and yes, you form C3b and all that stuff deposits, and that's how you get the kidney disease. But when you have infection, you don't have the C3 when you need it. And C3, converting it to C3b, it does another thing, and that is that it converts to something called inactive C3b. And inactive C3b is formed with the help of factor I. And inactive C3b, despite its name, does play a role, and it interacts with complement receptor 2, CR2, which is expressed on B cells. And the interaction between IC3b and CR2 stimulates B cell differentiation, and so it stimulates the B cells. I believe it would probably help you make immunoglobulin too. So these patients, this is another reason they're at risk for the sinopulmonary infections. All right, I think that's all I want to talk about. So this is membranoproliferative glomerulonephritis. Don't worry about reading pathology slides for step 2, step 3, but I want to illustrate some things here. So this is a normal glomerulus. Note that you have your capillaries coming through here, you have your macula densa over here, you've got, let's see here, you have Bowman space. So this is a normal glomerulus. And what I want you to note is the difference here. So this is why it's called membranal proliferative glomerulonephritis. This is membrane here. All this pink stuff is part of the membrane. And you have inflammation of that membrane, and you also have more membrane being laid down. So it's proliferating and it's inflamed. With membranal proliferative glomerulonephritis, you will note neutrophils in here, although it's kind of hard to see here. But there are neutrophils here, and then this proliferation of the membrane. And this ultimately is going to be help us diagnose MPGN, but you need a renal biopsy to make the formal diagnosis. So there's your normal glomerulus, and then note the MPGN. You got another picture here. So again, you see proliferation of the membrane. Okay, remember this. So what you can do if you want to diagnose MPGN, you can also get a anti-C3 antibody immunofluorescence stain. And that is exactly what this is. So what you're looking for is deposition of C3, and that's what you typically have with MPGN. And if you were to do this in this child, you would be able to get an anti-C3 antibody stain, and you would see that there is diffuse infiltration of C3 in the glomerulus. Oh, shoot. And you know what? I didn't put on here, and I was going to. But another thing you see in MPGN, and again, this is sort of a step 1 thing, but if you were to do a silver stain or periodic acid shift stain of the glomerulus, you would be able to see sort of a tearing apart of the basement membrane, and you would get that on either side of the membrane, you get that black deposition, and it looks like a train track, and that is called tram tracking, and that's a feature that you see in MPGN as well. Darn it, I wish I'd put a picture of that on here, but I guess it's not too important because you're not going to get these pictures on step 2 or 3, but good to know. So these patients are also at risk for vasculitic rash. Vasculitic rash kind of looks like what you run into in, you see this, sometimes you can see this in lupus, although it could be different if they have a discoid presentation of lupus. You also, well, let's see here. Okay, so neither of these patients have C3 deficiency, but this is a vasculitic rash. I'm not going to go into this too much because C3 deficiency is not tremendously common. All right. Okay, so factor I deficiency. This is different from C3 deficiency, but it has some similarities, actually some major similarities. And it makes sense if you know what factor I does, that it would have similarities, because ultimately this is really just going to lead to a C3 depletion anyway. So factor I, please note, this is factor I. This is the letter I, not the Roman numeral 1, so this is not a coagulation issue. This is factor I deficiency. This is a rare autosomal dominant disorder that affects the CFI gene, the CF1 gene, although we don't really see that in people. That's mostly something that biochemists and geneticists study in fruit flies. But anyhow, CFI gene is what's affected here, and this is going to result in primary deficiency of factor I, and this is going to cause C3 depletion. Why does this cause C3 depletion? Well, what does factor I do? I talked about this when I went over sort of ad nauseum our complement pathway back in the early complement section. But factor I is a serine protease which is responsible for cleaving C3b into IC3b, and active C3b, which we already kind of talked about. And it also inhibits the C3 convertase activity of C3b. So by doing that, it really serves as a check on our complement cascade pathway. If you lose that, then what are you going to have? You're going to have a deficiency of IC3b, and you are also going to have unchecked conversion of C3 convertase, converting C3 into C3b. So go back here. So you look at your pathway here. Factor I. So factor I is going to inhibit C3b, BB, the convertase, and then it's also going to promote the conversion of C3b into inactive C3b. So you lose factor I, you're going to have insufficient IC3b, which remember is responsible for B cell activation, and then you're also going to have a deposition of C3 components everywhere because you're converting C3 too much, and it's also going to lead to a deficiency of C3. So you can see some commonalities between C3 deficiency and factor I deficiency. Just different way to get there. All right, back here. All right, so we are talking about susceptibility both to pyogenic infections and Neisseria infections, just like in C3 deficiency. And then you're also generating excessive C3A, and that can degranulate mast cells and result in hives. I suppose this could probably happen in C3 deficiency as well, but this is something that happens in factor I deficiency. These patients, what can happen with them is that they might, so they're degranulating their mast cells. They might take a shower or go outside in the hot weather, and that is just enough to degranulate more mast cells to result in hives. And the reason for that is sort of like a tachyphylaxis thing, where they're used to the amount of mast cells they're degranulating, but then once you put them into a situation where they're going to degranulate even more mast cells, they get this sort of anaphylactic hive-like reaction. There is an increased incidence of hemolytic uremic syndrome and TTP in factor I deficiency, and so that can be managed. So a lot of this goes for all of these. So you will vaccinate these patients against encapsulated bacteria, so meningococcal vaccine, streptococcal vaccine, Haemophilus vaccine. You'll manage any autoimmune complications, fresh frozen plasma for acute episodes of hemolytic uremic syndrome and TTP. This is just if necessary. And then prophylactic antibiotics may be useful for factor I deficiency. However, their immunodeficiency is not as bad as with C3 deficiency. So with C3 deficiency, like this patient that we had in our vignette, one of the things that you may want to do for him is to provide him with prophylactic antibiotics. So something maybe like ceftriaxone. And this hasn't been studied that much. And so I don't want you to think that this is something you're going to just do if you happen to find this, which would be rare, but if you happen to find it on a test question. Because this is really going to be an immunologist that is going to make this decision. But there are discussions in the literature about providing prophylactic antibiotics, and really it makes sense because Neisseria meningitidis causing meningococcal meningitis, that is deadly. You can die from that very easily. It can cause fulminant adrenal failure. Remember your Waterhouse-Friderichsen syndrome, which is associated with N. meningitidis. And so you can, to say nothing about going into sepsis and all that stuff. So it certainly would make sense to provide prophylactic antibiotics. I mean, we do it for other things. But really, this is not something that is... I haven't been able to find it in like Medscape or any of the other... Let's see here. Go back. There we go. I haven't been able to find it in Medscape or in like UpToDate or anything like that. So I don't want you to come off thinking that this is something that is absolutely required, but it is something that's being discussed. Okay, so you probably have noticed that these factor deficiencies are really not, and complement deficiencies are really not, the management is not really defined very well. And the reason is just because it's so uncommon. Most of these are so uncommon. Now we'll talk here about something that's a little bit more common, at least in Japan. So that's C5 deficiency. And this looks almost identical to C6 through C9 deficiency. And the reason is because you need C5 to form your terminal membrane attack complex. everything before that is going to be pretty much normal. So you have no problem with your classical, lectin, alternative pathways. You have no problem making C3. You have no problem with opsonization. You've got your chemotactic factors, C3 and C4A, that are all there and able to allow for inflammation. So for the most part, you're fine. However, you can't form a membrane attack complex, and that's a big deal. You need a membrane attack complex to fight off certain gram-negative bugs, namely Neisseria. So these patients will have the same phenotypic susceptibility to Neisseria infections as those with terminal complement deficiencies, C6 through C9, which we'll talk about in the next section. This happens to be more common in Japan, along with C9 deficiency, which is common in East Asia, Japan, Korea. And that will stand in contrast to like C8 deficiency, which is a little bit more common in the general population, particularly among African Americans here in the U.S. C5, in addition to forming C5b, which is part of your terminal membrane attack complex, also forms C5a. C5a plays several different roles, just like C3 and C4a. C5a serves as a chemotactic factor for neutrophil migration, T and B cell migration, and then mast cell degranulation. And patients with C5 deficiency happen to have an increased rate of lupus incidence as well. So don't really know why that is. So our workup, and I talked about this in the other section, but patients with repeated sepsis or Neisseria infections, especially if they're young, or in the setting of autoimmune disorders, or in family history, you would think possibly complement deficiency. And typically, we're doing other immunodeficiency workups, as we did in this patient in the vignette. Typically, we're looking at B cells, we're looking at T cells, we're looking at respiratory bursts and all that stuff, because those things are just more common. Complement deficiencies only make up 2% of all the primary immunodeficiencies, so not very much. But if you do all that and it all checks out, then you can go ahead and get tests for complement deficiency. Or if obviously you have a patient who has immunodeficiency plus lupus, that's definitely an indication for getting complement titers. Or if you have a patient who has infections, but particularly Neisseria infections, which is what they struggle with the most. In that case, you also want to get complement titers as well. So you start out, you can get the CH50 and AH50, and like I said in the previous section, it's really analogous to getting PT and PTT of your coagulation pathway. So what this does is it tests a path. So it's not going to tell you what factor is deficient or what complement is deficient, but it will tell you what path the issue is at. So we have a classical pathway and then our alternative pathway, and then they kind of coalesce. And so if both the CH50 and the AH50 are low, then you should consider something further down the road where these coalesce, so namely C3, C5, or terminal complement deficiencies. You can also get specific complement assays. I would hold off on that unless you have a patient with lupus where you're really thinking C2, C3 deficiencies, or if you if you already got your CH50, AH50, and now you want to hone in on a specific factor complement. And then flow cytometry can be done both for MCP and for mannose binding lectin, too. We talked about that in the other section. All right, so for the most part, what I want you to get from this is that as you transition from your early pathway to the terminal pathway, what you're going to get is early on, if you have deficiencies, so like C1, C4, C2, you're more likely to present with lupus. Not so much immunodeficiency, because remember, you have 3 different pathways to work on. You have a classical pathway, a lectin pathway, and alternative pathway. If you have a problem on one side, you can usually make up for it on the other, and so your immunodeficiency is not quite as bad. C3 and C5, however, that's a common pathway. So if you're screwed up there, then you're going to have significant immunodeficiency. And I want you to remember the correlation between C3 and factor I deficiencies with membranoproliferative glomerulonephritis. And you can have membranoproliferative glomerulonephritis without the setting of immunodeficiency, but you'd still have a low C3. And that's important too. So when you talk about a lot of these glomerulonephritides, a lot of them are, some of them, so lupus nephritis and MPGN, some others, are complement deficient. And if you go back and look at my section that I did on glomerulonephritides, I talk about how you can divide them up into complement deficient and normal complement glomerulonephritides. And indeed, MPGN is one of the low complement glomerulonephritides. That having been said, I believe that's everything I wanted to talk about here. If you have any questions, go ahead and let me know. I will talk to you in the next section.